This session is titled Interstitial Nephritis, Overview for the Boards. My name is Julie Pack, and I'm an associate physician in the renal division in the Department of Medicine at Brigham and Women's Hospital and an assistant professor of medicine at Harvard Medical School. This slide just contains some information about me and my background. I have no disclosures. So let's get started. The objectives of this session are to use 3 case vignettes to highlight common causes and features of acute interstitial nephritis and to highlight common causes and features of chronic interstitial nephritis. Let's start off with a question. A 42-year-old patient was referred by her primary care physician with new onset azotemia. Her serum creatinine had increased from 0.9 milligrams per deciliter to 1.96 milligrams per deciliter over a 2-week period. 1 week prior to presentation, she had been seen by her primary care provider for a new onset cough and yellow tinged sputum and was empirically started on a 5-day course of levofloxacin. What is this pathology pattern? I'll give you a moment to review the choices and answer the question. The correct answer to this question is acute interstitial nephritis due to the drug, which was levofloxacin. And we will go through these common causes as well as the reasons for this one in a moment. So let's delve into acute interstitial nephritis. So renal biopsy remains the definitive diagnostic modality for acute interstitial nephritis. And the hallmark that is found on the renal biopsy are several features, including an inflammatory interstitial infiltrate of monocytes and lymphocytes, interstitial edema, renal tubule separation, tubulitis, and an absence of glomerular or vascular pathology. Fibrotic changes can be seen, though, as early as within 7 to 10 days after the onset of interstitial nephritis. Granuloma patterns are also commonly drug-related and can occur in this setting. So let's talk about the clinical presentation of acute interstitial nephritis. So this is a table from an article in Kidney International from 2010, and here we can see that while the traditional triad that we are taught about, including fever, skin rash, and eosinophilia, does occur, there are other signs and symptoms that are much more prevalent in the clinical presentation of interstitial nephritis. And these other features include acute renal failure, microhematuria, non-nephrotic range proteinuria, and leukocyturia. That being said, we do see the classic triad of fever, skin rash, and eosinophilia in about 10% of cases. So what are the etiologies of interstitial nephritis? So we can break them down into 4 major categories. The most common etiology is drugs. About 3/4 of the cases are due to drugs, and antibiotics are a common offending agent. The mean delay between the drug start date and acute kidney injury, it can be up to 10 days, but there can also be a latent period as short as 1 day with some antibiotics. The next major category are infections, and they can be bacterial, viral, or parasitic. Third, systemic diseases are another common cause of interstitial nephritis, including autoimmune diseases such as sarcoidosis, lupus, Sjogren's, and ANCA vasculitis. Neoplastic causes such as leukemias and lymphomas, as well as acute allograft rejection. And then finally, there is an idiopathic category, which is less common, accounting for approximately 5 to 10% of cases. What are the pathologic changes that we see? So these are the major features. 1, inflammation, edema, second, and lastly, fibrosis. Let's turn to a couple of pathology slides demonstrating the changes that we see on the pathology here. So first, the arrows indicate the interstitial inflammation that occurs with interstitial nephritis. Here we can see that the blue arrow points to the interstitial edema that we see with interstitial nephritis. And third, with more chronicity, we see interstitial fibrosis, tubular atrophy, and we can also see benign hyaline casts. So let's turn to our first case to illustrate some of those points that we've been discussing thus far. So the patient is a 75-year-old male with a history of hypertension and metastatic melanoma who presents with acute kidney injury. He presented with nausea 1 week prior without emesis or diarrhea. He has had no recent contrast administration, no NSAIDs or other new medications. His melanoma was diagnosed approximately a year ago, and 6 months later, he had noted a left submandibular mass. The biopsy had revealed metastatic melanoma. Subsequently, he was enrolled in a clinical trial of combination therapy with ipilimumab and nivolumab. They are both immune checkpoint modulators. And so the first one is an anti-CTLA4, and the second one, the nivolumab, is an anti-PD-1, PD-L1 checkpoint inhibitor. The patient received 2 cycles of treatment with these immune checkpoint modulators, but his third cycle was subsequently held when his creatinine was noted to be 4 milligrams per deciliter on routine labs. His baseline creatinine, though, was 1 milligram per deciliter, and the most recent creatinine was a month ago at 0.9. His past medical history is notable for malignant melanoma, hypertension, no family history of kidney disease or melanoma, and his medications are only these immune checkpoint modulators. On physical exam, his heart rate was 93, and he was hypertensive with a blood pressure of 178/80. He was producing approximately a liter of urine per day, and his the left submandibular mass could be palpated. He had a jugular venous pressure of 10 and lower extremity edema. On the laboratory findings, he is noted to have metabolic acidosis with a bicarbonate level of 18, BU165, an elevated creatinine of 4, no eosinophilia. He was also noted to have ANA positive at 1:40 ratio. And on renal ultrasound, his right kidney was 12.4 centimeters, left kidney 13 centimeters. His urine sediment was notable for multiple white blood cell casts and no EOs. So here is a slide showing the changes that we see on the biopsy for acute interstitial nephritis that is likely drug-induced. And so here, in this patient's case, it was related to the immune checkpoint inhibitors that he had been treated with for his metastatic melanoma. And drugs, as I mentioned earlier, is the most common cause of interstitial nephritis. So this slide demonstrates or illustrates the number. Can we just pause that? Let me just reword that to 2118. So this slide highlights the different classes of drugs that can cause interstitial nephritis. Most commonly, antibiotics can cause interstitial nephritis, and some of the different classes amongst the antibiotics include beta-lactams, quinolones, sulfonamides, and other antibiotic classes. However, antibiotics are not the only type of drug that can cause interstitial nephritis, and there is a whole array of different classes, including diuretics, NSAIDs, proton pump inhibitors, H2 blockers, allopurinol, as well as other classes. It's important to note here that in the cases of drug-induced interstitial nephritis, that it is not dose-dependent, and recurrence or exacerbation can occur with repeat exposures to the same or related drug. Now that we've reviewed drug-related interstitial nephritis, let's move on to the second major etiology of interstitial nephritis, which are infections. So the infections can be caused by bacteria, and here this slide lists different bacteria that can cause interstitial nephritis, different viruses, as well as other etiologies. So it's important to note that when someone presents with acute renal failure and interstitial nephritis, that it could be related also to a systemic infection. Let's move on now to the third major class, which are systemic diseases. As I mentioned earlier, they can be autoimmune, neoplastic, or also acute allograft rejection. And finally, idiopathic interstitial nephritis is uncommon, but in these cases, fever is quite common. And let's go into more detail about one particular type, which is tubulointerstitial nephritis and uveitis symptoms. So the boards tend to like this IgG4 related disease. And this is a constellation of systems that are involved in IgG4 related disease. And what this slide demonstrates is that many different systems can be involved. In particular for the kidney, what we can see in IgG4 related disease is a tubulointerstitial nephritis or membranous glomerulonephritis. What are the clinical features of IgG4 related tubulointerstitial nephritis? So here we can see some of the common laboratory features. The overwhelming majority of patients have an elevation in their serum total IgG levels, IgG4 or hypergammaglobulinemia, and over half have hypocomplementemia. On imaging, the majority of patients show radiographic abnormalities in the kidney, including small, low attenuation lesions that are usually bilateral and multiple, or a mass. And a few patients, there can be enlarged kidneys. What is the course of interstitial nephritis? Most cases resolve with removal of the offending agent or treatment of the underlying infection if infection is the cause of the interstitial nephritis. However, according to different studies, approximately 30 to 70% of patients did not fully recover their baseline renal function, and up to a third of cases may require dialysis. The likelihood of recovery of their kidney function is inversely proportional to the degree of renal failure. How do we treat interstitial nephritis? So as I mentioned in the previous slide, the best treatment is removal of the offending agent or treatment of the underlying infection. And so as an example, with NSAID-induced interstitial nephritis, it would be to withdraw the offending drug. Steroids are a mainstay of treatment in idiopathic interstitial nephritis, as well as tubulointerstitial nephritis that are associated with systemic diseases. Other treatment modalities include cyclophosphamide, cyclosporin, as well as mycophenolate mofetil. And there have been some studies that have examined the use of plasmapheresis or cytotoxics, although this is not necessarily a mainstay of treatment. What are the current recommendations for steroid use in the treatment of interstitial nephritis? So it's recommended that patients should be treated who do not have significant improvement in the creatinine within approximately 3 to 7 days after discontinuation of the offending agent. A renal biopsy is preferred for several reasons: to confirm the diagnosis of interstitial nephritis, to exclude other possible diseases, and to assess the presence of interstitial nephritis with significant chronic damage. In which case, if there is significant chronicity to the interstitial nephritis, it may be that immunosuppressive therapy may not be indicated in those cases. An empiric trial of steroids for patients with a history that's strongly suggestive of drug-induced interstitial nephritis may be warranted when kidney biopsies are not feasible. Nonetheless, the optimal dose and duration of therapy with steroids are unclear. So prednisone can be administered at a dose of 1 milligram per kg per day for approximately 1 to 2 weeks with a gradual taper for a total therapy duration of 2 to 3 months. In more severe cases with acute kidney injury, IV methylprednisolone could be used. And the duration of steroids varies widely amongst the different studies and cohorts that have been studied this far, in the range of days to months. So what is the take-home message regarding acute interstitial nephritis? First, in terms of the clinical symptoms, the triad that we are traditionally taught about in textbooks, the fever, rash, and eosinophilia, while it is present, is only seen in approximately 10% of patients. And there are other symptoms that are highly prevalent in the presentation of interstitial nephritis. However, that being said, not having these symptoms does not necessarily rule out interstitial nephritis. The next take-home point is that drugs are the cause of the majority of cases of interstitial nephritis. So it's very important to take a thorough medication history, and most of the drug-induced cases of interstitial nephritis improve spontaneously after stopping the offending agent. And the clinical suspicion for drug-induced nephrotoxicity should be high because unfortunately delayed intervention can result in poorer renal outcomes. And finally, steroids remain the mainstay treatment option for interstitial nephritis. And that being said, the optimal dose and duration are currently unclear. Let's move on now to chronic interstitial nephritis. In these cases, there are a diverse spectrum of etiologies. However, despite the diverse spectrum of etiologies, there is a fairly homogeneous pathologic pattern that is seen on biopsies. And these are the most common features of chronic interstitial nephritis, including interstitial fibrosis that causes tubule separation, tubule cell atrophy and or dilation, tubulitis and luminal cellular casts, and we can also see fibrointimal thickening. Here is a slide showing some of these changes, including interstitial fibrosis, tubular atrophy, as well as benign hyaline casts. What is a clinical presentation of chronic interstitial nephritis? So oftentimes here, the patient can be asymptomatic or have symptoms of chronic kidney disease, and they may have an incidental finding of an elevation in creatinine as well as an abnormal urinalysis. In these cases, anemia tends to occur early, and there is hypertension in approximately 50% of cases, as well as acidifying and concentrating defects. And in a biopsy series, other features included non-nephrotic proteinuria, microscopic hematuria, pyuria, as well as glycosuria. This slide highlights the diverse etiologies of chronic interstitial nephritis and some of the different categories. So here we see hereditary diseases that can lead to chronic interstitial nephritis, including polycystic kidney disease and medullary cystic disease, metabolic etiologies, drugs and toxins, immune-mediated systemic diseases, including sarcoidosis, lupus, Sjogren's, Wegener's granulomatosis, hematologic etiologies, such as multiple myeloma, light chain deposition disease, sickle cell disease, paroxysmal nocturnal hemoglobinuria, lymphoma, as well as systemic infections. Let's move on now to the second case. We have a 49-year-old female who presents with a 4-month history of nausea, fatigue, nocturia, and an 11-pound weight loss. Her past medical history is significant for herpes zoster approximately 2 years ago. She self-medicated with a Chinese herb for approximately 3 months. And she's been taking this medication intermittently in the past 18 months, and her last use was approximately 5 months ago. She denies taking NSAIDs. On physical exam, she's found to be hypertensive without edema. Her labs are notable for the following. She has hypokalemia with a potassium level of 2.9, metabolic acidosis with a bicarbonate level of 18, an elevated creatinine at 1.5, BUN 54, and she's found to be anemic with a hemoglobin level of 10.3, On the urinalysis, it revealed 3+ protein, glucose, as well as 3 to 4 red blood cells, no white blood cells, no casts. And the renal ultrasound revealed a left kidney at 10 centimeters and a right kidney that was 9.8 centimeters. An analysis of the Chinese herb that she had been taking showed that it contained aristolochic acid. So here's an example of the pathology that can be seen in patients with aristolochic acid nephropathy. We can see diffuse tubular atrophy and interstitial fibrosis. So just a note about aristolochic acid nephropathy. It is a rapidly progressive interstitial nephritis that can lead to end-stage kidney disease. The first case was reported in Belgium after an outbreak of renal failure in approximately 100 young women. And another name for this type of nephropathy is Balkan nephropathy. And with aristolochic acid nephropathy, which can cause chronic interstitial nephritis, some of the key morphological findings include, in addition to interstitial fibrosis and tubular atrophy, as well as complete tubular disappearance, is a gradient of intensity ranging from most severe in the outer cortex to less involvement in the inner cortex and medulla, so thus a stripe appearance. And also of note is that the glomeruli are relatively spared. In terms of the clinical presentation of aristolochic acid nephropathy, it can develop as early as 2 months after exposure or as late as 3 years after discontinuation of the drug. And the condition is commonly seen in young females, although it is not exclusive there and can be seen across all populations. Patients are typically asymptomatic, and the diagnosis is usually made through an abnormal laboratory finding indicating renal insufficiency. The proteinuria is relatively mild and the anemia is more severe than the degree of renal failure would indicate. The majority of patients have hypertension, and the course to end-stage kidney disease is subacute, but is faster than what would be seen in other tubular interstitial nephropathy cases. And here, just a comment about the proteinuria. And it consists of 5 low molecular weight proteins. And it can be detected before there's a demonstrable decline in the kidney function. So moving on to our third case related to chronic interstitial nephritis. Here we have a 66-year-old female who was recently diagnosed with hypersensitivity pneumonitis. She has had a waxing and waning dry cough along with fatigue and weight loss for 9 months. Her creatinine at the onset of illness was 0.8 milligrams per deciliter and progressively worsened over several months, so that by the time she was hospitalized with community-acquired pneumonia 1 month prior to presentation, her creatinine had climbed to 2.5 milligrams per deciliter. 2 days prior to presentation, her outside labs revealed a creatinine of 3.5 and hypercalcemia with a calcium level of 13.3. She has been taking supplements, including fish oil and vitamin D, since her last hospital discharge, and she denies the use of NSAIDs as well as other medications. Her physical exam is notable for hypertension, lack of elevation of her JVP. She does have crackles at her left lung base, no edema or rashes. Her labs are notable for the elevated creatinine at 3.2 milligrams per deciliter, metabolic acidosis with a bicarbonate level of 20, and of note, hypercalcemia with a calcium level of 13.5. On renal ultrasound, her kidneys were normal in size without hydronephrosis, and a CAT scan of her chest was notable for improving ground glass opacification in the left base, no hilar or mediastinal lymphadenopathy or nodules. So here is a slide that demonstrates the diffuse granulomatous interstitial nephritis that can be seen in the setting of hypercalcemia in patients with sarcoidosis. So on the right side with the blue arrows, you can see that there. So a comment about sarcoidosis. and the interstitial nephritis that we can see with the systemic disease. So the kidneys are affected through hypercalcemia, but at the same time, not all patients have hypercalcemia. More have hypercalciuria as well as concentrating defects. And then up to approximately 15 to 30% of patients can have non-caseating granulomas at autopsy. And in general, they respond well to steroids. So a 55-year-old male presents with renal insufficiency, kidney stone hypercalcemia, hypercalciuria, and a renal biopsy is performed. What is the diagnosis? I'll give you a moment to think about this and select your answer. So the correct answer here is sarcoidosis. As was demonstrated in the previous case of the female patient with sarcoidosis, we oftentimes can see hypercalcemia as well as hypercalciuria. Here, in this case, we have a patient that has a chronic interstitial nephritis pattern due to sarcoidosis that includes granulomas that can be either with or without multinuclear giant cells. So what is the natural course and treatment of chronic interstitial nephritis? Most are unfortunately slowly progressive, and the key to treatment is treating the underlying disease as well as eliminating any offending agents, as well as treatment of the sequelae of chronic kidney disease, including blood pressure control, treatment of electrolyte disturbances, and in some cases where warranted, treatment with steroids. Biopsy is often not indicated because of the lack of specific therapy. Over the course of the past half hour, we've reviewed the common causes of acute interstitial nephritis and chronic interstitial nephritis. Acute interstitial nephritis can be caused by drugs, infections, systemic diseases, as well as idiopathic etiologies. And the key to treatment is to identify the offending agent and remove the offending agent, or to treat the underlying infections or systemic diseases. In some cases, course of steroids may be warranted for the treatment of acute interstitial nephritis as well as kidney biopsy. We also talked about chronic interstitial nephritis and the diverse etiologies that can cause chronic interstitial nephritis, as well as its course and treatment. Through the three cases, I hope that we've been able to illustrate here examples of acute interstitial nephritis as well as chronic interstitial nephritis. And these two questions were able to help you assess and visualize some of the pathology that can be seen in cases of interstitial nephritis. I'd like to acknowledge several people who helped with the creation of these slides for this talk on interstitial nephritis, including Dr. Lili Shao, Dr. Helmut Renke, Dr. Vanessa Bijol, and Dr. Ragnar Paulsen. Thank you for your time and your attention.